It's my pleasure to introduce the speaker for our plenary session. We met in the lift this morning, both of us slightly frantic because we were both slightly late for being somewhere else and then realised who each other was. But anyway, it's my great pleasure to introduce the leader for palliative care, responsible for the new strategy in Wales, Dr. Idris Baker. Welcome. Thank you.
Thank you very much. It's a real delight to be here, this side of the border, which doesn't happen to me often. And I just want to offer some thoughts, which I hope will stimulate some digestive juices ahead of lunch, but maybe some conversational juices as well, about the work we've been engaged in and are engaged in Wales. And I'm going to start by saying I'm not stood here because we've got all the answers. I'm not stood here because we've sorted everything out. This is very much work in progress, and a bit of me was, in preparing for this session, was wishing I could be talking to you in about 5 years' time, when we might actually have made more progress on some of the things I'm going to talk about. But I hope that it's of some use to talk about them now in that spirit of humility, because there is much to do. But as I say, I hope some of these thoughts will be useful. It's particularly interesting to me to be following the Michael Howard Award, because Lord Howard, as you may know, hails from my part of the world, grew up very near Swansea, and was educated, in fact, looking at this photo which I took on the Gower Peninsula, where he went to school, is just out of shot to the right of this photo. And that's not the reason I'm showing the photo. I just like showing off what I consider to be my office, because my main job, and being National Clinical Lead is a kind of hobby activity, my main job is as a largely community-facing adult palliative medicine consultant in an integrated department, so a hospice-supported unit, but sitting within and managed within the NHS, and an integrated department with an inpatient unit and the hospital support team based there and the community team based there, and that's the main thing I do with my working day. So this is my office, and essentially in my part of the world, being a community palliative medicine consultant means they pay me to drive around the Gower Peninsula, having the privilege of seeing people at home. The photo may also be something of a recruitment strategy, so if anybody's looking for a change of scene, if you fancy having an office that looks like this, then you know who to get in touch with. Palliative care in Wales, as in other places, has been going on a long time. And it's worth looking back a little bit as we look at where we are and where we're trying to get to. The physicians of Myddfai were a family of herbal physicians who were the medics to the royal court in the kingdom of Deheubarth, the physicians to the Lord Rhys. And this is a later write-up of some of their wisdom. They knew a lot about plants. They knew that a lot of the plants they could find in their woodlands locally had anti-inflammatory and analgesic properties. But they knew that a lot of these anti-inflammatory plants also caused a bit of gastric upset. And among those various plants they used, they knew that the meadowsweet seemed to cause less gastric upset than some of the others. And they postulated, while they didn't have the science to be able to pursue this, they postulated that that might be because, as well as an anti-inflammatory agent, it might also contain something protective. Botanists now tell us that meadowsweet contains both a salicylate and a prostaglandin analog, and the clinicians amongst you may know that that's what was finally put into a compound formulation, but it took the pharmaceutical industry till the 1990s to do that in the form of Arthroptec. The physicians of Myddfai knew it 8 centuries ago, wrote it down. It's not just a tale, it's not just a boast. They knew about the importance of symptom control, but they knew about the importance of side effects. They knew about the importance of seeking to mitigate those and striking a balance between the two as they tried to work out what would give value to the people in their care. There's a lesson there somewhere, is there not? This, as far as I know, isn't a photo of my great-grandmother, but it could have been. Because when she was a district nurse riding around Mid-Wales in the 1920s and 1930s, they did eventually give her a nice motorcycle like this one. This is a district nurse, I think, in Scotland at about the same time. Palliative care has been going on a long time. My great-grandmother, some of what she did was probably assisting GPs doing kitchen table appendectomies in the 1920s in Mid-Wales, because that's what you do. But a lot of what she would have been doing would be what she perhaps wouldn't have called, but we might call palliative care. Is it not? we probably all have our local unsung heroes. This is the great Dr. Peter Griffiths, who was the person who caught the vision for a hospice in West Glamorgan in the 1970s, gave up his comfortable GP partnership, went to learn at the feet of Cicely Saunders how to do it, how to run a hospice, came back to Swansea, launched the campaign, did the fundraising, and set one up and served as medical director and subsequently chair of the hospice trustees in his own retirement. We all have these figures, don't we, who we can look back to and look at, well, something made them go and do that. Something made them develop and nurture that kind of radicalism, that thinking differently, to take the theme you've had the privilege of looking at this week particularly. And that's what has brought us perhaps to where we are, and you would each have your own local stories of that. I want to say something about the context in Wales, because I appreciate the majority of you perhaps are a little less familiar with it. So we have a population of between 3 and 3.5 million, which is overall a little bit older than the background population of the UK. Much of it dispersed, but with areas of dense local population in a handful of urban centres, in primarily south, but also some in the north of Wales. Overall, higher rates than the UK average of some serious and sometimes progressive and life-shortening illnesses, and that may relate partly to the age profile and partly to the industrial heritage, which of course has put some of the population at risk of some of those. Overall, substantially lower average household incomes than the UK as a whole, less than 75% of the UK average household income. And you will know in the services you work in and support the effect that can have on the work that hospices and palliative care teams do. We have a thing called devolution, and health was one of the things that was devolved to being run within Wales at the onset of devolution in 1999, so 24 years ago now, with what was initially called a National Assembly, but now Senedd Cymru, the Welsh Parliament, and the executive of that being the Welsh Government. And so health is fully devolved, as are a number of other important areas, education and social care and so on. So most of the sort of government and policy side of things that's relevant to this conversation is devolved within Wales. And Wales has a slightly different set of structural arrangements for the NHS than operates in England. So we have 7 integrated health boards, typically serving a population of between 300,000 and 600,000 or 700,000 people. One of them, which covers a very large area in the middle of Wales, Powys, serves a much smaller population. There are many, many more sheep in Powys than people. As a complete aside, did you know that veterinary palliative care is now becoming a thing? I kid you not, there is serious thinking, particularly in the US, about whether we shouldn't euthanize animals, but should actually care for them instead. There's a thing. Anyway, that's a conversation for another day, even though there are many sheep in Powys. So maybe Powys is the place in Wales that will start doing that if anybody does. We have a growing role for digitisation, and the thing about being a small nation, a small country, is that you have the opportunity to do some of these things nationally. And that, and I'll make some comments about it shortly, is giving us some scope for making better linkage between different forms of data we have. And of some significance to this conversation, we have very strong cross-party support for the recognition of the importance of palliative and end-of-life care. Forgive the acronym on the slide, but palliative and end-of-life care, and hospices specifically. So we have a degree of stability in that sustained support. Now, there may be cynics in the room who would question whether that support always translates into all of the answers to the important questions that one might want, but I couldn't possibly comment on that. We do at least have the recognition, and that means we have the access, we have the conversations with government quite actively. And of course, colleagues in Hospice Cymru, as the Wales wing, if you will, of Hospice UK, are important and really in the forefront of those conversations, for which we're grateful. We have some variation between different geographical areas of Wales in the balance of provision from the voluntary hospices and the NHS. And to expand on that a little, we have areas where there are voluntary hospice organisations, in some instances local organisations, in some instances part of wider UK national organisations, which provide important elements of the palliative care including inpatient units and including community teams in a number of areas, alongside the important provision in the NHS, including specialist palliative care in cancer centres and hospitals and so on, and of course the important, and we'll say a little more about it, picking up on the photo of the woman who wasn't my great-grandmother, the community facing non-specialist services like district nursing. We have other areas then where there's no voluntary hospice being operated in the voluntary sector, but where we have the equivalent, we hope, and again we'll come back to that question, equivalent provision within the statutory sector integrated within the Health Board. That happens to be the case in my little corner of Wales. So we have that variation. And that's a kind of variation that you could see, and we'll come on to some of this language, you could see as warranted variation. Maybe there's more than one way to skin a cat. Maybe it's okay that we do things a little bit differently in different places. That might be because of different local need. It's more likely, and I think this is the case with this example, more likely to be just flukes of history. But maybe that's okay for there to be different ways of meeting the same need. But some of it might be unwarranted variation. Some of it might be that some needs can be met in some places and not in others. And that's a theme that we will clearly need to come back to. Where we have got to then in that context is with a lot of work by some very able people over quite a few years, particularly over the last decade and a half, is that we've got to the point of really having quite strong multi-professional specialist palliative care services across Wales for adults with needs for palliative and end-of-life care, and for children with needs for palliative care and hospice care. We have a degree of equity, for instance, in being able to provide 7-day a week and 24/7 support, 24/7, 365 days a year, for adults and for children respectively, with tiers of on-call rotas and so on. So anyone living in any part of Wales has, at least in principle, some kind of access any moment of the day, if they need it, to some palliative care support. That's progress. We have what I think I can say with confidence is seen as world-class, particularly postgraduate education through university courses at different levels that are offered to equip the specialist workforce, but also, again, importantly, some of the non-specialist workforce with an interest. We have postgraduate medical training. Not that medicine is the only important profession, but it happens that maybe a slightly more systematic attention has been paid over the decades in the UK to the postgraduate training in palliative medicine than in some professions. And again, that may be a thing that we need to come back to. But you know, we have a training scheme in Wales which recruits pretty well. And we've been able to develop a pipeline between academic research and policy, which has been both important and influential. Research grant funders like to know that the work they fund may actually translate into something being done. And so I could think of a couple of examples in the last 5 years or so of studies that have been conducted in whole or part within Wales, then translating into policy. A couple of examples to give you. The bereavement scoping study that was done, as it happens, just before the pandemic, was one of the key evidential influences in developing for Wales a national bereavement framework. We have a national bereavement steering group set up by Welsh Government, which brings together providers and other stakeholders and has developed a bereavement framework. And one of the main substrates for developing that was the bereavement scoping study, a well-conducted academic study conducted in part in Wales in cooperation between Cardiff and Bristol universities from memory. And a second example, and you may know of the need that a number of patients and families perceive for a form of empowerment in a lay carer being able to give subcutaneous injections for symptom control at home, which technically is the easiest task in the world, isn't it? Let's be honest. And they do it with insulin, they do it with heparin. And for decades, people have been asking about this. And for decades, idiots like me have believed what I was always told, which is, no, you can't do it, it's not lawful. And I look back and I shudder that I was stupid enough to believe it, because of course it's not true. It's not true. And a study done in Wales demonstrated some of the, pulled together really, some of the evidence about what it takes to be able to support lay carers to do that. You need the right training. The technical task is easy, but you need a bit of training for it in drawing injections up. But more important than that is the decision about whether to give it. Anybody who's ever given a subcut injection to someone who might be nearing the end of life knows the emotion of feeling, what if they die in the next hour? Will I end up blaming myself? Well, try doing that if that's your mum. Right, that's tough. That's tough. So you need a lot of support in the training, and then you need decision support at the time that a lay carer might be able to do that. This is some of the evidence that came out of a study, again, led in Wales, and at the start of the pandemic, we spotted the opportunity because government was suddenly moving quickly, wasn't it? Some of it seems to have slowed down again, but some aspects, certainly in Wales, that's my only experience. Other governments are available. But in Wales, my experience was the government suddenly started moving quite briskly and quite effectively. And so my academic colleagues were able to turn their research output, which we discussed on a Friday afternoon, into a policy paper which was accepted by Welsh Government on the Monday morning. And away we go. And that's in use in some parts of Wales where lay carers can be supported with that. So we have that research policy pipeline, and that's beginning to work. In paediatric palliative care specifically, we have a degree of all Wales coverage, There are some important inequities and gaps, and they still need to be addressed, but a degree of coverage. 2 children's hospices. There may be people from both of those here. I can't see clearly enough with the lights in my eyes, but 2 children's hospices, which between them can offer support to any child and family living in any part of Wales. So we've got that degree of coverage. And in the adult palliative care world, we've got a close link between the specialist and the non-specialist workforce, which, as I've alluded to a couple of times, does actually most of the adult palliative care. We say sometimes some, don't we? But it's most. Just to illustrate that, this is just a snapshot of a dashboard which has been developed in Wales using data linkage methodology to demonstrate something about the particular focus on the use of unscheduled care services of people who are in the last 12 months of life with a progressive life-shortening illness. So for Wales, this is the 2021 cohort, as the most recent cohort I had access to that had been validated when I was putting this together, but the numbers are reasonably stable year on year, apart from a blip in the pandemic. So we had almost 35,000 people in Wales. That's typical, just over 1% of the population. That would be the case, I think, in any area of the UK broadly. And in this donut, the lighter coloured bit is the ones, 34%, who were at some point in that phase seen by a palliative care specialist. It's a third. 2/3 who were not at all. Now, and I'm not saying that's not okay, because it may well be, I hope it is, that the 2/3 who were not were getting some brilliant intervention by GPs, oncologists, district nurses, community physios, OTs, social workers, whoever it might be, outside of what we would regard as the specialist palliative care sector, including the hospices in Wales. We have data systems that gather that information across the statutory and voluntary sector. So 2/3 were not seen by a specialist. Of the third who were seen by a specialist at some point, you'll see on the bottom right of the slide, the median interval between their earliest encounter with a palliative care specialist and death was 32 days. And that means that everything before that period, and the median, as I say, being 32 days, I mean, there's a very wide spread there, because some people would be referred at the last minute and some early, but everything that went before that referral, evidently, is being done entirely by people who are not palliative care specialists. Now, we just need to be a little bit careful in jumping on late referrals as being a problem. Sometimes they are. Sometimes they're not. I spent, I hope, a fairly productive Friday evening a few months ago in the emergency department of my local hospital with someone who happened to be the mother of a colleague, and that may be part of how I got to hear about her, who on Wednesday was living with a serious illness, but pretty stable. On Thursday was moderately acutely unwell, needing some attention. By Friday morning was seriously sick and in the emergency department, and probably going to need admission to hospital, thought quite possibly to need an operation for an arterial embolus, a limb ischemia. That was what was thought to be the problem on Friday morning. By 4 p.m. on the Friday, it's clear the diagnosis is in fact necrotizing fasciitis, and she is now too sick and too frail to have any definitive treatment for that, is not to be admitted to intensive care, is polysymptomatic and in need of some support. She died at 10 o'clock that evening. She had 6 hours of palliative and end-of-life care need. There was no indication for a referral to a specialist before about that time. There certainly was by 4 o'clock, and she got one, and she was sorted out actually largely by the very capable emergency department staff. We shouldn't denigrate the skill they bring to the table either, should we? Any Muppet can tell you that it's not good to die in the ED, but stop and have a look at what those staff do when someone is going to die in the ED, and they're often magnificent. Okay? So sometimes late referral is the appropriate thing, but I think we all know that sometimes the late-ish referral that's reflected by that median interval of 32 days is sometimes a problem. It's sometimes because no one has spotted earlier than that two important things. It may be that no one has spotted the need to involve a specialist, but it may be, perhaps more gravely, and again it's a theme I'll return to in a moment, it may be that no one has spotted that there is a need for a palliative approach, full stop. That, I think, we too often see is the case, isn't it? But what this tells us, what these data tell us, is that the bulk of the work that's being done with people with palliative and end-of-life care needs is actually being done outside of what we might regard as specialist services, those whose core business is doing this. And of course, even for the people who are being seen by a palliative care specialist, you know, I might have very close contact with someone. I'm almost certainly not the person who's going out at 2 o'clock in the morning to give the next subcut injection, am I? It's probably a district nurse in my part of the world. Other services operate in different places. So this close connection, and I know it's something that you and your organisations will have been closely focused on, this close connection between specialist and non-specialist workforces is then of crucial importance if we're going to make the kind of difference that is needed by people with these needs. So we try to do some of that. But there's got to be a but, hasn't there? And here's the 7 examples of things that I think, well, we've got work to do. We have some persisting inequities. I touched a moment ago on the theme of unwarranted variation. It may be that some things can be got by people in some corners of Wales and not in other corners of Wales. Again, I think Wales is not unique in that. How do we know that? We know it partly by anecdote at the moment. We know it because I spend some of my time going around finding out about it. But we don't even have a complete picture on what some of those persisting inequities might be. We don't have all of the data that we might need to know. I grew up in an era, and some of you may have done too, when the hospice movement and palliative care as a whole was still a relatively new thing being done at relatively small scale by a very small number of people and recognising it wasn't capable of meeting everybody. And we used to throw around the phrase a little bit of heaven for the few. I can't remember who coined that. You may have heard it. And there's an important principle in ethics. I dabble in academic ethics. And there's an important principle, which is ought implies can. In other words, you can only do what you can do. It can only be said that you ought to do something if you can do it. It can only be said that you ought to help everybody if, in fact, you have the capacity to help everybody. And if we don't, then we mustn't beat ourselves up about not being able to do so, but we should do what we can. It's an important thing. You're not going to survive long in a field like this unless you can remind yourself that ought implies can. But there's a corollary of that. There's a corollary of that, which is don't leave it there. The corollary is don't leave it there. Don't satisfy yourself with a position where you can only help, where you can only offer a little bit of heaven for the few. And of course, the pioneers of the organisations in which we've all worked are people who wouldn't settle. They're people who wouldn't settle. Cicely Saunders could have said as a student in the 1950s or as a nurse in the 1940s, oh, well, I can't do much about it, so I won't bother, and she didn't, and none of the rest of you have either. That's why you're sitting in this room. Your presence here and this conversation is emblematic of a refusal over sustained periods of time to say that's good enough. Because good enough isn't good enough, is it? Yeah, I'm digressing a little, but you get the point. These persisting inequities, whether they're because of geography, or whether they're because of other factors, other characteristics, aren't things we should settle for. There's inequity according to diagnosis. I said that 34% of those people in the data we have get seen by a palliative care specialist at some point in that final phase. That's 80% if you've got cancer, and it's less than 20% if you've got dementia, frailty, some organ failures. And we've told ourselves historically, well, someone else can do that. Can they? Can they? Do we know? Well, I've got to tell you, we don't actually have all the information that tells us whether those people are, in fact, getting the support and intervention which we know they need. And we do know, don't we? Because people have been publishing high-quality academic work on this now for 4 decades. When I started out in palliative medicine, we used to complain that we didn't have enough evidence and it was a data-free zone. Well, we've got plenty of evidence on that, haven't we? Plenty of evidence on the need of these different groups living with different illnesses and those close to them And so where there are inequities on that basis, we have to consider them. There may be inequities about age, and they may, of course, be linked with diagnosis-based inequities too. I've often been told in my career that young people with young families are more complicated, so they're particularly in need of specialist intervention, the support of a hospice, the support of a specialist palliative care team, and that older, frailer people getting towards the end of their lives are less complicated. Are they? And they're not, are they? And again, the evidence is there. Incipient cognitive impairment makes for important changes in how you process symptoms and in how you process the response to interventions for those symptoms. Changes which complicate assessment, changes which complicate decision-making. You lose the placebo effect, that's one characteristic. You need intact cognition to get the placebo bit of benefit from your painkillers. You lose that with progressive cognitive impairment. It makes the assessment of your symptoms and the response to that assessment more complicated. Now, that's just one example. We could think of many, many others. Maybe it's actually the older people who are more complicated. I don't know. We don't have all of the data, do we, to tell us what the experience and the outcomes are for those people who don't get referred, do we? So we have to be concerned about persisting inequities. There is, and this will come as no surprise to this conference, there is persisting concern about funding for hospice services. I don't need to tell you much about that, but it's a thing, isn't it? And a conversation we're having quite actively, which, again, I'm grateful for the perspective and the advice and indeed the challenge that comes from our hospice partners and from Hospice Cymru. There's a relative dearth of the systematic measurement of experience. I say relative because there are good examples of patients and patients' experience and the experience of those close to them, call them families, call them what you will, being measured. There are good examples, and again, this is one of the areas where the radical innovation of the hospice world has put hospices out in front of the NHS in terms of that measurement. And so we're trying to learn something from how hospices have done that. But there's a relative dearth of the systematic measurement of that. And by systematic, I mean across the entire system of people's care, rather than just measuring their experience in one service. There's a case for measuring it across that wider spectrum. There's a near complete dearth of the systematic measurement of outcomes. Clinical outcomes, patient-reported outcomes, proxy-reported outcomes, there are various outcomes that might be important, and the measurement of those has been in silos and at quite small scale in Wales, as I think in other places. I spent years being told you can't do it, you can't measure outcomes in palliative care, they're all going to die, aren't they? And that's kind of a definitive outcome, and that's 1 out of 1, so you can't do outcomes measurement. And of course, it's complete nonsense. It's complete nonsense. I got very bored of hearing it. And so we don't accept that anymore. And I'll come on in a moment to say what we're in the process of doing about that. Because you can't just moan about stuff, can you? You've got to do something about it. Yeah, and again, that's why you're sitting here. We have uncertainty about the timely identification of palliative and end-of-life care need. This is a persisting concern. We know there is sometimes good timely identification. And I know some of the sessions you've been at in this conference will have talked about that, but we know that's not consistent. That is not always the case. And again, I'm not talking here just about timely identification of the need for a referral to a particular service or the involvement of a particular team, but timely identification of the approach that's needed. We think that's not consistently done, but perhaps more importantly than that, we don't have the data that tell us precisely. We have an uncertain track record on translating research into practice. Now, I've said something about the research to policy pipeline, and we've got that working reasonably well. But actually getting important clinical research, and again, we're past the era when we could whine about not having any research output, any evidence on which to base our decisions. The track record on actually translating that into practice is a little more patchy. I had the pleasure a few years ago of sitting in another conference in the audience listening to an academic from another part of the world. And I mean, he'd been hired to do a job and he did it well. He coruscated us for not doing enough of this. He said, you animals, you've been moaning for years about a lack of evidence. I've given you 2 randomized controlled trials that say this particular drug you love doesn't work and you're still using it. How dare you? It's a pretty robust challenge, but he had a point. Now, there's a riposte as well, and I won't bore you with it, because the studies were a little bit flawed. So maybe there's a place but actually engaging seriously with that evidential output, that research output, and using it to inform our clinical practice is a really important thing. I'm not going to be satisfied on this one. I'll give you my kind of bellwether for it. The analgesic ladder was published by the WHO, 33 years ago now? Perhaps unsurprisingly, colleagues, the evidence on the place of weak opioid analgesic drugs, step 2 in the ladder, has changed a little in the last 33 years. What a surprise. People have gone and done good studies that have refined our understanding of what, if any, place that particular class of drugs have. I mean, it's fine for people like me, people like you to know that. I'm not going to be happy until every prescriber for people with palliative and end-of-life care needs knows that and deploys that in their practice. What's the point of doing the study if the people who are doing most of the prescribing don't know anything about it? We've got work to do, haven't we, in how we translate that research output into clinical practice. And a seventh problem, if you will, challenge, we've got pretty much no idea what all of this activity costs. We know what the hospices cost, okay? You guys, you run tight ships and budgets, and, we can talk about that information. We do as a national programme with our hospice partners. Similarly, the specialist services within health boards, it's reasonably easy to phone up the right manager and find out the information about the budget. So, we've got figures for what some of the specialist services at least are costing, although even that can take a bit of work. What does it cost district nursing? What does it cost in general practice? What does it cost oncology? I mean, it's really difficult to know. So, we're trying to make progress on that. And there is some progress that you can make on that. I showed you a screenshot a moment ago from the dashboard we use that gathers and links data, different sources of data, on the utilisation of unscheduled care services by patients who, retrospectively, have died within 12 months, excluding those who die of a sudden illness. So those people, we can broadly say, will have had palliative and end-of-life care needs towards, for a period. Maybe that's 6 hours, like my colleague's mum, or maybe some years. And you can find, can't you, notional costs for a 999 call, an ambulance attendance, a presentation to the emergency department, a day in an acute hospital following presentation to the emergency department. So you've got notional costs for that. We can count how many of those things happen, and it's a relatively simple mathematical task, isn't it? Now, I don't have the figures because we're waiting for them to be validated, but it may not surprise you that out of Wales, I think that the published budget for the NHS in Wales, which of course will include elements of the commissioning of hospices, is about 10 billion per annum. That's just as a ballpark figure. The amount that's spent just on those 3 items of unscheduled care utilisation, ambulances, EDs and acute hospital beds, by people in the last year of life with progressive life-shortening illnesses, is well into 9 figures. I mean, we're talking hundreds of millions. Okay? I mean, eye-watering figures, actually, for a bean counter or for a minister. I have the pleasure of conversations with our health minister on this theme. But actually counting what all of this costs, we may be able to get an idea of elements of it, but getting a whole idea about what this costs is actually really difficult, because the system isn't set up well enough to know that. And again, I think Wales is probably not unique in that. These are some of the challenges we deal with. So we have to work out what to do. As I've said, it's no good just whining about these things. So what does it mean in the context that I've laid out? What does it mean to think differently? Thinking differently being such an important prelude for doing differently. You've been thinking differently these 3 days. I hope you're going to go back to your workplaces and translate that thinking into doing. What does it mean to think and do differently then? How do we go about trying to meet some of that existing unmet need? Because, I've laid out for you some of the reasons for thinking that there is already some unmet need, and deal with, and again, I know you've heard something about it in this conference, not least from Chris Whitty on Monday, about the projected growth, not only in numbers, and the projected growth in numbers over the next few decades is a bit eye-watering, but I'll tell you what's dwarfing that, and again, I know Sir Chris told you something about it, is the growth in complexity. We think that is growing. I mean, you could reflect it in the degree of multimorbidity, couldn't you, as a crude indicator of complexity. It's a very crude indicator, but it's not a bad one because it's quite easy to count. We think that's growing much more quickly than the numbers of people with needs for the care you and your organisations provide. How are we going to tackle all of that? How are we going to tackle the questions of inequity, those challenges I've laid out? How are we going to tackle the questions of quality? Because it's no good doing equity without quality. It's no good levelling down. It's no good on the question of projections. It's no good just counting the numbers of people and saying, right, okay, there's going to be a 40% increase over the next 20 years. That's roughly the headlines, isn't it, from the literature? 40% increase in the next 20 years. So we're going to have this number of people. That might be about 45,000 per annum in Wales. So we'll increase by that amount, and we'll see all of those people once the day before they die. We can tick the box and say we've done palliative care for those people. We've referred them to the hospice for their support. We've done it once for each of those people. That would be no good at all. It would be equitable, maybe, sort of. We've done the same thing to everybody. I mean, it's a very crude, impoverished vision of equity, isn't it? It would be no good. So how do we tackle the question of providing decent quality? How do we tackle the question of actually delivering value? And that's a word that can operate in a number of senses. I mean it as something, just to be clear, much richer than, again, the very impoverished concept of value for money, although that is not important. How do we add to what people value in this phase of their lives? How do we do that? How are we going to tackle those big, big questions? Well, W. Edwards Deming, he may have been being tongue-in-cheek in saying, "In God we trust." It's a cultural phenomenon in the US where he was writing. Just as an aside, I would say that sincerely, so I'm not saying something glib in quoting him in saying that. But I'm interested in the second thing he said, which is all others bring data. All others bring data. If we're going to tackle these questions, if we're going to think differently and then, in fact, go and do something, we need to do something with data. So let's think then for a moment about how we can understand what good we do. We had a consultants meeting about a year ago in Wales, and as a team-building exercise, we had a baking lesson. And it was mainly so we could eat cake. That's always good, okay? But we had a baking lesson as a team-building exercise, and we were talking about value in this meeting. So it set me thinking as I was preparing my cake to put in the oven. It set me thinking that we've talked about the research output. That gives us the recipe. You can have a perfect recipe for your cake. Perfect recipe doesn't make a good cake, does it? We learnt that in my baking lesson, if nothing else. So the recipe was fine. You've got to follow it. So you need processes that tell you whether you are in fact following the recipe, okay? And the analogue of that is perhaps processes of audit and quality improvement and so on. Are you actually deploying the evidence in correct process in your clinical care? But you know what you haven't asked yourself in doing that is, how's the cake? Is the cake actually any good? You can have the perfect recipe and you can feel in every way that you can measure and demonstrate that you followed that perfect recipe perfectly, and the cake can be rubbish. Maybe there were unmeasured things, unmeasured respects in which you didn't actually follow it as well as you thought you had. You've measured some headlines, you've missed some important stuff. You missed out important steps, and they weren't measured and you didn't spot it. And you're satisfied because you know your recipe's great and you've done your audit, so you're happy. How's the cake? Or it may be that you've actually made a perfect chocolate cake for someone who really needed a fruitcake. I mean, I'm in danger of stretching this analogy to breaking point, aren't they? Okay, so I'm going to leave the analogy there, but you get the point. You get the point. We have to know something about the outputs. And I'm going to talk a little about those outputs, and namely specifically outcomes and experience, as well as the inputs. What's it costing you? What are you having to invest in time and resource and staff and infrastructure to deliver all of this? You have to know about those outputs, or you're not going to know whether you're really doing the right thing. And that's the concept of person-centered, value-based health and care, which we will talk about. This will tell you something about the models that you might need to establish and commission, might tell you something about the models you need to drop, because they're not adding the value you hoped they would be. Again, I think the hospice movement has been a lot smarter about stopping things than the NHS has been at times. You'll know that the core definition, this is the definition offered by the Centre for Evidence-Based Medicine in Oxford of value-based healthcare. The equitable, important word, sustainable, also an important word. No good having funding up to March, is it? Yeah? What's going to happen in April? So the equitable, sustainable, and transparent. The sort of no decision about me without me, engaging people in these decisions. Use of the available resources, wish they were more, they are what they are. How do we know we're doing our best with them? So the use of those resources to achieve better outcomes and experiences for every person And then in the case of a particular system, every person who needs that system's support, people with needs for some form of palliative or end-of-life care. And crudely, that leads you to focus on doing more of what helps, doing less of what doesn't. And you're doing that by focusing not merely on process and structure, although, again, those are not unimportant, but having this close focus on what's actually the relationship between what you're putting in and what people are getting out. And it's important in any area of health and care, of course it is, but I think the subjective element, the person-centeredness, acquires a particular importance with the work that you do, that I try to do. Simply for the reason that the physiological goals you can achieve are much more constrained. Now, if you're measuring outcomes and experience for people who need a hip replacement, it's reasonable to say, well, reduced pain and improved mobility are kind of key examples of indicators, because you can achieve those. And maybe you can afford to put a little bit less weight on the subjective domain. But if you're dealing inherently with a group of people to whom you can no longer meaningfully offer long life and good health, because they're living with serious problems which are not going to go away, and at some point for most of the people we see, are going to truncate their earthly life, then the subjective preference that sits within that becomes so much more important. Given what we can't achieve, here's the importance of what I need. So person-centred approaches to palliative and end-of-life care become particularly important, and person-centred approaches to measuring value. Doing it in a way that uses standardized measures, because you need those for lots of reasons, but does them in a way which can acknowledge the subjective, acknowledge the person. Absolutely crucial. So, with all of that in mind, where we have got to then is we have a national clinical programme established in Wales in the context of this new overarching executive structure for health care in Wales, seeking to deliver on these kind of principles, guided by a quality statement. It's there, it's in the public domain, it's easy to find. It was published by government a year ago, a quality statement which has been co-produced not only by people like me, but also by people who are not palliative care specialists but have an important perspective, important set of contributions, and people like you've been hearing from at other points in this conference who've actually got lived experience of being on the receiving end of some of the things we do, and members of the public and so on. So we have this quality statement which sums up, I've got to tell you, there's not many surprises in it. Okay, sums up some of what we all know to be important. But there may be a few surprises for some of us, because if your perspective is limited, you may miss some other bits. Look, we've got a programme overseen by a board, informed by a series of professional and advisory groups, some of which we've co-opted, long-established professional fora, which we've said, okay, will you take as part of your terms of reference a formal role in offering not only advice but challenge to us as a programme? And we've set up some other groups, including, importantly, groups bringing together the expertise of hospices and other voluntary organisations in the adult and in the children's sector, again, to advise and inform the programme. And I mean, they are the programme, they're doing a lot of the work of the programme, but also, crucially, and this is not lip service, it's something we positively encourage because we need it, to challenge. To challenge, because there's a distinctive kind of challenge that's needed and that can be brought by the hospices. And we have a work programme as a programme that's informed partly by what government asks us to do. We're a small country, and so government will get in touch and say, right, we need advice on what should we do, what's the service specification, what are the right models, what should we be supporting, what things should we not be supporting. That's an important decision for government to make, isn't it? But also informed by the priorities that are identified in practice, and so from the various stakeholders and groups. And I want to highlight really just three areas that we're working on as a programme in an attempt to show how we can actually embed some of these principles. So I've talked a little bit about the advisory role, and that's ongoing work. We've been working on patient experience and the systematic measurement of it. And we've piggybacked onto a new system that the NHS in Wales as a whole is using to get feedback on people's experience, patients, carers as proxies for patients who are no longer in a position to comment on their own experience, including because they may have died, but also carers as respondents in their own right. And we all know that's crucial, don't we? To capture their own experience as well as asking them, how was it for the person who's died? And we've been able to piggyback some bespoke questions designed to measure the experience of palliative and end-of-life care onto that, and we're in the early stages of implementing that, and at the moment that's really being done within some of the specialist services in the NHS and starting to get some of the hospices involved in doing that. But you'll know from what I said earlier that the vision needs to be that we're capturing that experience across the board. I don't worry too much about the experience of people who are cared for by a hospice, to be honest. I know it's going to be great. I know what you're like. I go and I've visited, I've trained in hospice. Some of my best friends work in hospices, okay? I know that's going to be great. Now, maybe I shouldn't be quite so complacent, actually. We do need to measure that. Maybe it's not always perfect. Am I allowed to say that? Okay, so we do need, in fact, to measure that experience. But they're not the ones that keep me awake at night. The ones I lose sleep over are the ones you don't get to see. What's their experience? Because we don't know, do we? We don't know. And so having experience measurement that is just done within one particular wonderful team isn't going to answer the most important questions. So we're moving to implement that in a way that's system-wide, and that's going to be absolutely crucial. And it's going to tell us hard things. It's going to challenge our dogmas about the people who don't need referring to us. If you're working in a service that spends more time explaining what you don't do because it's not specialist enough than doing what you do, this is going to hit you between the eyes. It's going to hit me between the eyes because some of the services that I work with might be vulnerable to the charge I've just laid out. So we need to know about those aspects of people's experience, don't we? And we need to do something with it when we know it. But you can't do anything with it until you know it. It's that important step. Similarly with outcomes. Again, this is the thing they said couldn't be done, so we've gone and done it anyway. We have agreed, and we've got a national consensus, again involving professionals and the public, a national consensus for adults, and it's work in progress for kids, but they're pretty close to it for kids, and they're different outcomes you need with children. For adults, we've got an agreed core outcome set, 21 items. It's the things you might anticipate being important. Again, not many surprises in it. And we've agreed a suite of tools which can deliver those outcomes, which you can use to capture those outcomes. And again, we're at an early stage with piloting in specialist services the use of those outcomes, the vision. And I want this yesterday. I'm often in trouble for being impatient about it because I want it yesterday. The vision is that we get to a point where all of those 35,000 people have timely identification of their palliative and end-of-life care need, and from that moment on are afforded opportunities at key time points to tell us, to report to us, the patient and carer reported outcomes. And I'm going to be interested in the outcomes for the people who are just below the threshold for referral to a hospice or another specialist service, and the outcomes for the people who've been discharged a month ago, as we heard about in the neuropalliation workshop earlier. What are those outcomes like? We don't know at the moment. We need a system that's going to tell us. We're getting there in delivering a system. It's going to take a little more time than I would like. But that's some examples of the work we're doing. And it leaves us with some questions. How do we centre the user perspective? And I mean centre, right? How do we do the no decision about me without me thing, not just in clinical practice, where I think we've got better at it over the years, but actually in policy terms? How do we, these are rhetorical questions, I'm afraid I'm not about to give you magic answers to them, they're work in progress. How do we get the right model? How do we understand more clearly what the future holds? Not just counting numbers of people who might need palliative and end-of-life care, but actually understanding the evolving nature of that need, not least the complexity. What's the right balance between the specialist and the non-specialist? Is our dogma that we've operated with for decades right? Or are there aspects of it that need to change? Are there people who are missing out? Perhaps. We need to know. It may not be easy to fix, but you cannot fix it until you know. All others bring data. And we need systems that will deliver those data, and we need then to take those data seriously, frightening as they might be. But what are the unintended consequences of a value-based approach? What's the risk, for instance, of failing to capture some things that add value? So you'll have heard people being snarky about, the fish tank. Oh, that's a luxury, you don't need a fish tank. A hospital ward doesn't have a fish tank. Why does a hospice need a fish tank? Maybe the fish tank's adding value. We know the meal service that we heard about in the Michael Howard Award. That's adding value. It may not be on someone's list of core clinical services, but I bet you could tell us about the value it adds. So how can we make sure that we don't miss, that we don't fail to capture things that are of value? Really important question, because if you fail to capture important aspects of what adds value, your value-based system will do more harm than good, because it won't be value-based. And you won't know. You'll miss it. Got to do that stuff thoroughly. We've got to understand variation better, which bits are warranted, which bits are unwarranted. We've got to understand how can we support hospices and we as a whole system, we, in my case, as a national programme, both to contribute as part of integrated systems, and that's important. That's important that there is that connection. And I imagine that in other parts of the country, as in some parts of Wales, that's not always easy to sustain, is it? That sense of connection with other parts of the system. But also to fulfil that distinct role, and you know plenty about it, and I've said about it. How do we support hospices in doing that? How do we get this right across the age spectrum? There are specific considerations, as many of you will know, for children and young people. We've got those 2 wonderful children's hospices. We've got a bespoke 24/7 on-call rota. But there are challenges with that. There are challenges, and again, some of you will know them well. There is some degree of variation in what can be provided. There's the long and sometimes unpredictable duration of people's needs for that care. And the marked socioeconomic challenges and the consequent financial pressures on families, I'm told, is perhaps felt even more acutely by families with a sick child than on other families. What's the right workforce model? Big questions here, big questions. What professional mix do we need? What's the point in identifying the correct professional mix if you can't recruit to those posts? What does it take to be able to recruit and retain the right people? Pay's part of it, isn't it? That links with funding. Money does intrude on these conversations, but it's important. But so is the retention question, I think, isn't it? I used to work with a service outside of palliative care that really resented staff leaving. They said, we need to retain staff. And we had to change that. We had to say, no, it's a good thing when they leave because it means that in this post they've developed and they're going off to do something bigger and better. They're realising their ambitions. And if you want to recruit a new Band 5 staff nurse, he's going to need, your candidate is going to need to know this is a place where people develop, and I might be that person going off to be a specialist in 5 years' time with what I've learned in this job. So actually a bit of turnover is okay when it's for the right reasons. How do we get that understanding right? What's the relationship between what patients and families need and the professional standing of the person or people who need to be involved in meeting that need? If we had stuck with our view of that question 40, 50, 60 years ago, we wouldn't be having any of this conversation. You'd have doctors making decisions, nurses doing as they were told, no one else getting a look in. So the reason we have this movement, the reason we can confront these questions is that we've got the heritage of being radical about that question. We need to continue to be radical about it. Yeah? You've been hearing, I think, in previous conferences about the role of paramedics. We've been doing some work on that locally. I'll spare you the detail now. But how can we get into that question and understand it properly? And getting the balance right between the statutory and the voluntary sectors, having a degree of consistency there, a degree of parity of attention. How do we best support that wider workforce who are going to continue to be doing most of the important work? Is there a single right model, or can we actually operate different models in different places? These are really important, outstanding questions to which I'll offer no concrete answers now. But broadly speaking, the approach we're trying to take is to broaden rather than thinking there's a single magic bullet into which we can invest everything. Just to finish then, we're trying to pull all of this together and developing a service specification that will say at least something about the what should be provided, maybe a little bit less about the how, because the health boards are autonomous and the hospices are autonomous. So no one likes being told exactly how to do everything, but we are going to be putting together a service spec that will tell government and will tell the providers and will tell the public, this is what you should be able to get wherever you live in Wales in relation to the needs you might have. With an emphasis on value, an emphasis on equity, that works across the statutory and voluntary sectors, across the whole of that spectrum of complexity and specialisation, and looks at what we're doing that's working and what we're doing that's not working and what we're not doing enough of and need to do more of. That's what it looks at. That's the opportunity to make contributions to that, and I'm sincerely grateful for the work that the hospices I get to work with do, not only in delivering that hands-on care and the clinical aspects of your work, but the challenge and the advice and the perspective which enriches what we are seeking to do. So thank you all.
Idris, thank you. That was inspirational, that was intriguing, that was informative. I know I should have stopped him earlier, for questions, but I couldn't bear to because it was so good. Thank you. Honestly, that was brilliant. Thank you so much. We're almost out of time, and I've got a pretty hard stop on this because we've brought the premiere of the film, the movie, forward from 12:30 to 12:10, so we can actually show it before the 1 o'clock break before the next session. So I'm going to just pick up a couple of things very quickly, if I may. The first is linked to your issue of you raised this about empowering lay people to do things. I think how do we do that? And also linked with that, I think it's to some extent we as, if you like, the non-clinical laity have allowed ourselves to be disempowered. We don't actually believe we can do anything anymore. So how would you suggest we get into that in a really serious way?
I think, you do it at the level of individual people and families and then use that to scale up and inform. And you ask them. You ask them about what they value, what's important, what is it you need. And you use that with that seeking, in that spirit of wanting to empower people, using what they can tell you about what's valuable, what's important to them, then you link it with your clinical expertise, your organisational expertise, and the Palliative project for lay carers giving subcut medications is a prime example. That came out of listening to patients and those close to them saying, oh, come on, why can't I be the one who does this? Someone listened to it, and then someone went away and did the hard work to understand it properly and to do the research that demonstrated what it took to be able to make that possible and safe. Now, you can do that with any number of examples, I think. So you listen to people and you scale it up and you commit to it, because you can only do it if you're committed to working in that spirit. Okay.
And one other question, if I may, which is, if the answer to the first part of this is yes, then the second part is what do we do about it? Do you think that the reason that a lot of people don't actually make it into refer into palliative and end-of-life care pathways is because other clinicians are actually quite scared, worried about having that conversation?
Yeah.
And if that's the case, what do we do about that, Idris?
Yeah. Well, again, a big question, and I haven't got a concrete answer to it because it's a big part of what we're seeking to work on. But there are elements of it we know, so we use the evidence we have. So there is some evidence on timely identification of that need, and there is evidence, and again, we've heard about it in other parts of the conference, about intervening based on that need, doing more good than harm, including, in a number of conditions, actually prolonging people's survival. That shouldn't be a surprise. Uncontrolled pain is really bad for your health, okay? Not a surprise, okay? But we've got the evidence, not just the conjecture. So deploying those two things, what do we know about how you can identify the need, and what do we know and can deploy in quite simple terms, like I've just done, about how a response to that need does good, not the harm you might fear, and you deploy those two key pieces of knowledge in individual encounters with clinical colleagues and in policy terms in what we ask organisations to do. Chief executives of NHS organisations and hospices respond to inputs, do you not? And so, I know in my health board, the things the health board pays attention to are the things the minister's office phone up and whinge about them not doing. So let's get that. Let's get a whole system that whinges at provider organisations because your stupid urologist won't make a referral and asks him to behave better. Because it is that simple. We've got to be bold about this. There's no point kind of soft peddling it. We've got to be bold. This is clearly necessary. If the same clinician wasn't doing other aspects of what the evidence tells us is needed, effective, safe, and wanted, then she would probably be struck off. This is that serious. Yeah. So let's change systems. And actually the advocacy, and the hospice is key in this, the advocacy with the statutory sector, with commissioners, this is what you must demand of the services you're commissioning and providing, because it's an important part of healthcare that you're neglecting at the moment, is absolutely key. The pharmaceutical industry do it, don't they, when they've got a new drug they want to sell, whether or not it's going to work, bluntly. Well, you know that the stuff we're talking about does work. So that advocacy at policy level and at individual professional level has to be, I think, an element of how we do that.
Thank you. Thank you so much. Can I ask you to show your appreciation, if you would, for the last splendid hour?